You can see the slides, sir.
Yes, I can see.
And the slides are moving.
Yeah, they are moving now.
So, good morning, everyone. Today we have a case presentation, and today we have a special faculty from AIMS Jaipur, Dr. Vaibhav Vashne. He's an associate professor in Department of Surgical Gastroenterology. Today we are doing a case presentation. Case will be presented by our resident, Dr. Krishna Vardhan. Yes, sir. Now, Krishna, you can start.
Good morning, sir. Shall I start?
Please start.
Yes. A 61-year-old retired employee, sir, resident of Bikaner, Rajasthan, came with chief complaints of yellowish discoloration of sclera and urine for 20 days, which is 3 months ago, and associated with loss of weight and loss of appetite. The reason for his current admission is fever for the last 3 weeks. History of presenting illness: patient was apparently normal 3 months ago. Then he started having sudden onset of painless, progressively increasing jaundice for 20 days. Associated with yellowish discoloration of urine and sclera, clay-colored stools, progressively increasing generalized itching, and however, there are no prodromal symptoms or fever are there for this patient. For which he had underwent treatment outside a hospital. They have done an intervention, following which all the symptoms have improved for the patient. Currently, his admission, currently it is associated with intermittent episodes of high-grade fever for last 3 weeks, not associated with any pain in the abdomen or not associated with jaundice. And it is also associated with loss of appetite and loss of weight for the last 2 months. It is around 12 kilos of weight loss. Currently, it is not associated with any vomiting, hematemesis, melena, or hematopoiesia. There is no complaints of fullness or lump in the right upper abdomen. There is no shortness of breath or cough. There is no recent onset headache, seizure, or focal neurological deficits, or bony pains. Coming to his past history, patient do not have any comorbidities. He did not have any history of pain in the right upper abdomen or dyspepsia in the past, and no history of any surgeries in the past. Coming to his interventions, he had underwent PTBD, left PTBD, which is internalized on 1st of May this year, 2023, following which he had 2 ERCs and stentings done, one on 9th of June and another one on 11th of July. Personal history: he is a chronic smoker. He smokes more than 1 pack of 10 cigarettes per day for the last 35 years, and he occasionally consumes alcohol. He is complaining of disturbance sleep because of his current symptoms. There is no significant family history, sir. Summarizing, he is a 61-year-old retired chronic smoker with no family history of malignancy, currently presenting with complaints of painless progressive jaundice for 20 days, which was 3 months ago, associated with clay-colored stools, pruritus, loss of appetite, and weight loss, which improved after left PTBD, and not associated with hematemesis, melena, hematochezia, or any swelling over the abdomen, with no past history of dyspepsia or pain in the right upper abdomen. So, shall I give my differential diagnosis?
Previous slides, Dr. Krishna, first slide.
Yes.
So, you started with yellowish discoloration of sclera and urine for 20 days. So, in your chief complaints, like you need to precise, like make them crisp. Like when you are saying progressive jaundice, you can say, because like you are at MCH levels, so progressive jaundice for last 20 days, 3 months ago, then anorexia and weight loss. So this will make your crisp. And for how long this was there, anorexia and weight loss?
Sir, last 2 months he is having the anorexia and weight loss.
So that you need to mention 2 months also. Okay, now go to the next slide. So here you have started with painless progressive jaundice, because here the first symptom was jaundice. So you need to explain only the jaundice part. You have mentioned in your next slide about the pain in the abdomen. So the better is to start with patient who presented with insidious onset of jaundice, which was gradually progressive, or what was happened. You have not mentioned like progressive in nature, you have mentioned. And then this, when you are saying this yellowish discoloration of urine and sclera, what is like, you have already mentioned jaundice. So why are you saying it again?
Okay. Understood, sir.
Okay, got my point?
Yes, I got your point.
Okay. Then at that time, he didn't have fever, like you mentioned, no prodromal symptoms of fever.
Yes.
Fever is recent onset only.
Yes, sir.
Okay, go back to the next slide. Go to your next slide.
Next slide, sir.
Yeah. So, go back to the previous slide. Yeah, this slide. So, how much was the fever? Like, has you asked him what was the grade of the, how much is the fever? Has he quantified the fever?
Sir, he
Associated
said
with
he
chills
was
and
having
rigor?
chills and rigors.
That you need to mention actually, मतलब, because this is important, because you are thinking under the cholangitis. So that is important. Or is there any other cause of fever? And what is he having chills and rigors?
Yes, sir.
Your voice is not Krishna. Hello.
Sir. Sir, just a minute, sir.
Okay.
Trial. 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 Trial.
Sir,
Yeah.
am I audible now, sir?
Yeah, you are audible.
Yes, sir.
So you need to like mention about the characteristic of the fever also here, because this is important. And then, as you mentioned here, pain in the right upper quadrant, or you can say right upper abdomen also. And this is you have written no jaundice
Yes, sir. Currently.
currently. Okay. Then you have mentioned 12 kg over last 2 months, but in your when you summarized, you have written that it is not quantified.
Yes, my mistake. Actually, patient has given it 12 kilos or 2 months.
Okay, so loss of weight, and then about the loss of appetite also, you need to slightly elaborate it, that how much his appetite is lost over the last 2 months. Okay, go to the next slide. So like in this, like when you are mentioning about lump in the right upper abdomen, so it is better to use that patient has no history of awareness of any lump, because he has to tell. So awareness of a lump is a better terminology when you are telling about negative history, or if whenever it is positive. So patient is saying awareness of a lump in so and so part of the abdomen.
Okay, sir.
Okay. And why you ask for hematochezia? Like,
Just to see that the patient is having any bleeding. It can be like periampullary malignancies can also be there. There is a patient is having a
will
bleeding.
it cause hematochezia?
No, sir, it usually do not cause hematochezia until unless it is so massive, it will not cause.
Right.
It can cause malina. It will
Usually
not cause.
it do not cause. So you do not, like, vomiting is okay. Hematemesis and melena is okay. But hematochezia is not required. Then awareness of a lump. Then a shortness of breath or chronic cough. Cough is a normal reflex. So better to use chronic cough. That will. Okay, go to the next slide. Why you ask for dyspepsia in the past?
Sir, I would like to know whether the patient is having symptomatic gallstone disease.
Which disease? Sorry.
Symptomatic gallstone disease, sir.
Okay. Okay, go to the next slide. Okay, next. Here, like, here you can mention that painless progressive jaundice for last 20 days associated with cholestatic features, because repeating again clay color stool pruritus is not good. When you are summarizing, you need to be very crisp. So presented with painless progressive jaundice with cholestatic features, anorexia and weight loss, which you have already mentioned, and with some negative history, important negative history. Again, hematochezia is not required here, and any swelling, instead of any swelling, and no history of awareness of any lump in the abdomen. Okay. Then why you think, like, what is your points in favor of periampullary malignancy in this patient? And like when you are mentioning a differential diagnosis, you have mentioned only these 4 diagnoses. You have no benign cause in your mind.
No,
So
sir, I do
you
not.
say obstructive jaundice, secondary to like malignant etiology, and also benign, because you should, if you are 100% sure, then it is okay. But it is always better to say some benign pathologies in the history part. Okay. So what is the points in favor of your differential diagnosis, first differential diagnosis? Why you think so?
Sir, the onset of the age of the patient and the duration, rapidity of increase of the symptoms, and along with weight loss and appetite. So I thought it is a more favor of malignant etiology. Obstructive jaundice more favor of malignant etiology.
Okay.
Coming to the differential diagnosis, periampullary being the most, there is no specific pinpointing feature towards periampullary malignancy. However, periampullary carcinoma being very common in our country compared to other causes of obstructive jaundice. So I kept in a first differential diagnosis periampullary malignancy. Sir. Other features can be carcinoma gallbladder, which is common in the northern part of India, hilar cholangiocarcinoma, and less likely to be carcinoma head of pancreas.
Why not carcinoma head of pancreas like above? Because your patient is a 61-year-old smoker, and the pain can be a late feature in C head of pancreas. It is not like classical.
Yes, sir, it is
C head of
also.
pancreas.
Yes, sir. It can also be one step ahead of hilar cholangio. It still can be, sir. But the only reason why I have not kept it in the order is that there is no palpable, there is no mass, awareness of mass or any fullness in the abdomen, which is against or any symptoms of vomiting, any vomiting history, gastric outlet obstruction. There was not, patient was not giving any such features.
But if it is a small tumor in the C head of pancreas compressing the bile duct, the patient will not have any awareness of a lump or such kind of symptoms, and even pain in the abdomen. It is the late feature when.
Sir, but the gallbladder will be usually distended with obstructive jaundice. Usually, gallbladder.
That like patient might not be able to palpate it. It is your examination findings.
Yes, sir.
So because being a elderly male patient, history of chronic smoking in the past.
Yes,
Okay. Why you think that patient underwent left PTBD in your history?
sir, the patient was not able to. He underwent this in an outside hospital for biliary drainage. PTBD with the internal stenting was done, sir.
So what is the reason, like why a PTBD has been done in the first go?
Sir, failed ERC. They
Is
attempted
there
the
any
first.
history that patient has underwent ERCP before PTBD?
No, sir.
So why
Patient was not.
failed ERCP?
Sir, maybe technical competence of the person who was there at the hospital, because it is they have evaluated him outside for jaundice, so they have thought it was difficult for them for treating, stenting this case.
Is there any condition where you directly go for PTBD instead of ERCP?
Very high up obstruction, cholangiocarcinoma is very high up.
Yes, cholangiocarcinoma. So that might be a possibility in this case also, because as you mentioned that patient is why it is not like cholangiocarcinoma as a first diagnosis?
Sir, nothing specifically points towards hilar also. It can still be hilar, but just based on history itself, we cannot.
What is the characteristic feature of history in cholangiocarcinoma that you can say, not confirmly, but that points toward cholangiocarcinoma?
The only thing is that there is no distended gallbladder in the history. No, other
So
than that,
that
there is
is very,
nothing.
patient will not palpate his gallbladder. Otherwise, it's a slow progressive jaundice. Patient have more of pruritus. It is not, the patient will see a yellow discoloration of eyes and sclera immediately, which happens other way around in periambulary or steatopancreas. So that's why diagnosis of making helicolangioplasty clinically is difficult. Okay. So any benign causes you can think of in this condition, or you have totally ruled out based on your history and
I can't
that there
think
is
of
no
any
benign cause?
benign cause, sir. I can't think of any benign cause, sir, in this case.
Okay. So next, like, tell your examination findings, please.
Yes, sir. General examination, patient is conscious and coherent, moderately built and nourished with BMI of 21, ECOG 1 with breath holding time of 24 seconds. Currently, there is no icterus, pallor, pedal edema, left supraclavicular lymphadenopathy, cyanosis or clubbing. He is hemodynamically stable. However, pulse was on the higher side with pulse of 98 per minute. BP is normal, 108 by 70 mmHg. He is maintaining saturation of 96% on room air and is febrile with respiratory rate of 18 per minute. Coming to the local examination of the abdomen, on inspection, abdomen is flat with umbilicus central and inverted. No scratch marks are seen. There is a scar of the PTBD seen in the epigastric region. There is no visible fullness or lump, no peristalsis, visible peristalsis. All quadrants moving equally with respiration. There are no dilated veins or sinuses. Hernial orifices and external genitalia are normal. On palpation, the abdomen is soft, non-tender. Liver is palpable 2 centimeters below the costal cartilage in the midclavicular line. The margins are firm and smooth. There is no nodularities. Gallbladder and spleen are not palpable. There is no thrill and hernial orifices are normal. Percussion liver span is 16 centimeters in left midclavicular line. There is no ascites. Tympanic note heard all over the abdomen. Normal bowel sounds, no bruit. On distal rectal examination, yellow stools are present, staining is present. There is no Bloomer's shelf, no blood or black pigmentation. Systemic examination, bilateral wheeze is present in the both lungs. Other than that, systemic examination is normal. So shall I summarize the findings, sir?
Yeah, please summarize.
So this is a 61-year-old male, retired employee, chronic smoker, presenting with history of painless progressive jaundice for 20 days, which is 3 months ago, along with cholestatic features, loss of weight, loss of appetite, without any hematemesis, vomiting, hematemesis, or melena. Now on examination, moderately built with ECOG 1 and breath holding time of 24. With clinically only the scar of left PTBD present in the epigastric region and no other, and enlarged liver with which has shown firm and smooth margins and no nodularity, and per rectal examination is essentially normal.
So do you think patient is having hepatomegaly in this case?
Can't exactly call it 2 centimeters.
Okay.
Just below
So
the coastal margin.
why the liver is enlarged in case of certain jaundice?
So because of cholestasis, the liver gets enlarged.
Any other better way to mention it?
Obstruction of the biliary system, the bile gets accumulated, and
Okay. Was there any tenderness in that area?
no, sir, he was not having any tenderness.
So okay. So what is your differential diagnosis after examination? Is there any change?
No, sir. There is no difference in my this differential diagnosis.
Okay, so like, how would you like to proceed from here? The examination did not reveal anything except for just mild, because liver span seems to be okay.
Sir, my examination, my proceeding will be first with an ultrasound and regular routine blood investigations for the patient.
Like to see his old records first, because he underwent some intervention in the past.
Yes, sir, I forgot. I would like to see his old records first, sir.
Okay, so what all things are available? What is there any history the patient gave? What has been done in the past?
Yes, sir. He told he had underwent PTBD and internalization.
Before PTBD, he must have underwent something like some imaging.
Yes,
So
sir.
did he give any
We have
history?
it. We have it, sir. So he had underwent CCT of abdomen on 21st of April. in
Okay,
which they-
like if suppose as you asked that if the patient like in the history there was no intervention, so you try to see an ultrasound first. So has he underwent an ultrasound? Has he undergone ultrasound in the past? No.
No, sir. He has no, sir. He didn't have an ultrasound. He has an MR.
Okay, in the initially.
Initially, only they have got a CCT and followed by MR.
Okay. So can we see the CCT image like what has been done in the past?
Sir, we don't have the images. We only had reports.
Okay.
We had got a CCT done in our center.
Okay. So based on CT scan, they did the PTBD
Yes, sir.
and then they stented the patient via
Yes.
ERCP. What is this technique known as?
Rendezvous procedure, sir.
Rendezvous procedure. Okay. So the CT scan finding, what has been done in the past?
The index CT scan for the patient, 21st of April. This has revealed a thickening involving the CHT, proximal CHT, maximum thickness of 4 mm with mild proximal dilated bilobar IHBRD, sir. Multiple calculi seen in the GB lumen, thickened GB wall, largest measuring 7 mm. Liver is enlarged with 18 centimeters level, mild hepatomegaly. Following which they have done an
Wait, go back
MRC.
to previous slide, Krishna, just CT scan findings. Okay, this is the only findings that are available.
Yes.
Okay.
So they have done an MR for the patient. Sir, gallbladder is partially distended. Biliary sludge is seen in biliary radicals. Both hepatic ducts are dilated with non-visualization of biliary confluence and proximal CBD. Right hepatic duct is 5 mm, left hepatic duct is 4 mm. Approximately length involved is 33 mm. No obvious soft tissue intensity is seen in biliary confluence suggestive of stricture. So again, following which the patient was advised for a higher center. The patient has been referred to a higher center for further management. However, the patient didn't go for further treatment. So he had stent block cholangitis, for which another CECT was done before ERC and stenting. This is on 1st of May.
Initially, he underwent PTBD and PTBD was blocked.
PTBD with internal stenting, sir. The PTBD was never kept in drainage.
Okay.
So CECT,
You
the
don't have
second,
a CT scan also of this report.
these are all outside, sir.
Okay.
So here we have, in the second CT, enhanced circumferential soft tissue thickening seen in the neck of the gallbladder with periductal spread along cystic duct, common hepatic duct, suprapancreatic CBD, which is almost 5 centimeter length of CBD is involved, and both hepatic ducts with involvement of primary biliary confluence. It was a long segment involvement, sir. And they have seen the separate segment 6 drainage of sectoral, segment 6 drainage is also seen. In this CT, they have mentioned that right hepatic artery is involved, which is different from the initial CT scan. So again, 31st, they have done another MR. The gallbladder is distended with a diffusely thickened edematous walls, 10 mm. Yes. With few intraluminal hypointensity seen, mild IHBRD noted on the right side measuring 4.8 mm. So these are the images, sir.
Okay.
Sir. In this, we can see both posterior right side posterior duct and the left duct are near coming close, but there is no formation of confluence, and the anterior sectoral duct is opening separately also, sir. This is also separate. Anterior sectoral duct is separate. There is loss in the CH, common hepatic duct and common bile duct. The segment is not seen, and the
Okay.
lower part of, we can see the lower pancreatic duct normally in this, sir. And this is the gallbladder.
Gallbladder seems to be distended.
Yes, sir. This is the gallbladder.
What is the reason when the patient is having hilar block?
Sorry, sir. What is that? It is a hilar block, sir. And the hilar block that is extending down, which is involving the cystic duct also.
Okay.
Yes, sir.
Why gallbladder is distended in this case?
Because
Usually,
the cystic duct opening is blocked. There is a mucocele, sir.
what is Courvoisier's law?
Courvoisier's law says that distended in case of distended gallbladder, it is seldom due to stones.
In a case of jaundice.
In a case of jaundice. In a case of jaundice.
And what are the exceptions to it?
Sir, it is the double impaction. Mersey syndrome is an Mersey syndrome, and if there is any parasitic infestations in the CBD, these cases are exemptions.
Okay.
So, sir, I would like to, then we have the patient presented to us. We have done a triple phase CECT in the month of July, which has shown bilateral mild pleural effusion. Images I will show. Sir, there are multiple lesions in the sorry.
Go systematically. Okay. So this is you need to explain this. This is the patient of your. Please.
This is
Okay,
a triple phase CECT, sir. This is the venous phase, the portal venous phase. Sorry, hepatic venous phase. This is a triple phase CECT, sir.
This is a triple phase ECT of my patient.
My patient. Arterial. This is currently in the arterial.
Done on, if you can say the date. So you need to like tell it when you are like opening a CT scan. So you have to say it accordingly that this is the CT scan of my patient. You have to check the name that you are seeing the correct CT scan, and then the date that this has been done on which date, because you have 3 CT scan in the past. So you have to mention it, and then this is the arterial phase, and you have to mention that this has involved the chest also, the lower part of chest, and chest, lower part of chest, abdomen, and pelvis. So I'm seeing that. Okay, now it's keep on describing what you are seeing.
So in the lower part of the chest, there is small pleural effusion on both sides and small area of atelectasis in the chest.
Okay.
And there are multiple which can be seen in the liver, hypodense lesions in both lobes of the liver, sir. In the both lobes of the liver, and there are few areas of pneumobilia are there. Few areas. These are the areas of pneumobilia we can see, and there is a stent which we can see in the biliary tree, sir. These are the stents which are placed in the biliary tree.
Okay.
Yes, sir. And the gallbladder is thickened and distended, sir. The gallbladder is uniformly well distended and thickened, sir. The wall is thickened. Yes, sir. However, because of the stent, we could not identify the thickness properly. Yes. So this is the area. This is the area of thickening. Only at the neck of the
visualize in venous. This is arterial. Okay. Complete the arterial phase first. Is there any arterial issues in it?
No, sir. No arterial anomalies, sir.
No arterial anomaly. Any? Can you see the whole course of right hepatic artery?
Yes, sir. I'll show you.
Yeah, please.
Yes, sir. Here, starting from here, the right hepatic artery. Yes, we can see the origin from the yes, sir. This is the origin from the celiac, where we can see the hepatic artery proper, and
Okay.
now we can see the right hepatic artery and left hepatic artery branching at this point, sir. Now we can even see the branches of right hepatic artery. Sir. This is the right and this is the left.
Okay.
Yes, sir.
Go to the next phase.
Hepatic venous. Hepatic venous phases. This is hepatic venous phase, sir. The same findings. The only thing that we can see the multiple liver abscesses, which are well defined in this case.
Not liver abscess. What is the correct term to use them?
Place occupying lesions
Sorry?
as well. Hypotense lesions.
Hypotenuse lesions.
As
And
well.
what is the characteristic of these hypotenuse lesions? What they are looking like?
Uniform hypotense lesions. Irregular.
Characteristic of what? What they're suggesting? These
Sir, liver abscesses looks like more on liver abscess, sir. Cholangular abscesses.
cholangular abscess. Okay. And how will you differentiate it from metastasis?
Metastases usually are round, well
Okay.
defined. The perilesional edema, there will be perilesional edema. These
Okay.
features will be
In
there.
this, you can see the margins are like very shaggy,
Yes, sir, very shaggy, irregular.
irregular.
We are not able.
Sir,
Okay.
next. Sir,
Okay, yeah.
blood investigations, sir. Shall I show the blood?
No, let's like go back previously. Now the patient was having initially, you said fever was not in the beginning,
Yes, sir.
but he underwent PTBD and then stent exchange. So why you think so? Why was they have done it? Like fever developed recent onset.
Yes, fever is a recent
only
onset.
painless progressive jaundice. So why the PTBD was done in the beginning and followed by stent?
PTBD most because the initial hospital people thought that TRC and stenting they could not have. It is technically difficult for them probably. That is the reason why they have done it PTBD.
They have done it, but why they have done it? Like why the biliary drainage was done? What is the reason you can think of? Because
ideally it is not necessary at that initial phase.
okay.
He could have been prepped for surgery, but that is the treatment physician's
Are there any reasons in which you can go for
Yes.
biliary drainage?
Yes, sir. The strongest indication being cholangitis, which is not
there. Okay. Other than that,
other than that, the patient's choice. Second is if the patient is nutritionally not well built, we can buy time. We can
I
stent
think
the
this
patient.
patient BMI is 21, if I'm not wrong. Okay.
Yes.
Any other reason?
Yes, sir. Other reasons being any social reasons for the patient. Other than that, patient is having any hepatorenal syndrome. Hepatorenal syndrome. If the patient is having increased creatinine.
Do you have any decreased urine output in the history? You mentioned about decreased urine output.
I have not mentioned, but
Please note it down that this is the history is important. If you are ruling out that is there any renal insufficiency, so history of decreased urine output is important in your negative history.
yes, sir.
Okay, next. Any other indication of doing a preoperative biliary drainage apart from cholangitis? You mentioned nutritional buildup of the patient.
Social circumstances of the patient.
Is high jaundice, high bilirubin level is an indication?
No, sir, not an indication.
if suppose bilirubin is 25 or 30, would you like to drain it?
No, sir. Not an indication until unless any of these factors are there. There is not indicated.
Okay, so if the bilirubin is 30, so you can directly go for surgical intervention.
Yes.
Okay, and what are the other any other indications? If the patient is planned for any neoadjuvant chemotherapy,
Yes. Neoadjuvant chemotherapy. Chemotherapy.
okay, because like in this patient, your primary confluence is involved,
Yes, sir.
and if there is a carcinoma gallbladder following primary confluence, so what is the usual surgical therapy? Or if there is
Extended right.
right episiotomy, okay. So would you like to drain the bilirubin in that case?
Yes, sir. We would like to drain.
So you said there is no, you will not drain it even if the bilirubin is 30.
Liver resections. If we are planning for a liver resection, then we have to.
That's
drain.
why the surgeon or whosoever has done it must have thought of operating this patient, and this might be an indication that patient bilirubin would be high. That's why they thought of doing a biliary drainage despite patient was not having fever. This can be a possibility.
Yes.
Okay, so like patient underwent PTBD and then he underwent ERCP and stenting was done.
Yes.
Okay, so then the patient develops fever after say 3 months he came. So what was the reason you can think of fever at current moment? Patient is already already stented.
Stent block cholangitis and cholangular abscesses.
Okay. So and this CT scan also collaborate with your findings with stent block, and because pneumobilia is very minimal and cholangular abscesses are there.
Yes.
So how you are going to manage this patient now?
Sir, first thing I would like to do is ERC and stent exchange.
Straight away, patient came to you in fever, having mild tachycardia, you straight away take him for ERCP.
No, sir. The first one is stabilizing the patient. Okay. I have to check his INR first.
You know everything. Like this is you do in your practice, but in your examination, you don't directly jump on what I know. ERCP is a treatment, but if you tell the answer systematically, this will give you a good impression that you are a good clinician. Okay.
First is to stabilize the patient, sir.
Yes.
We have to start with antibiotics,
Yes.
IV antibiotics, and second we have to see his INR to see if it is
Correct.
and INR. But if there is any abnormality, we have to correct it before any procedure.
Correct.
And then after which stabilizing, then we have to plan for the any procedure. The patient currently needs 2 procedures. The abscess, second is stent blockage. First, we will go for stent exchange, and then at the same time we will do the drainage of the abscesses, largest abscess, any large, more than 5 centimeter drainable abscesses.
Yes. I think in this patient there was one large abscess.
Yes.
So, okay, then what will you do? Like ERCP has been done, stent exchange has been done. Okay, can come to the laboratory investigations. What are the current?
So the current investigations show the hemoglobin is on the lower side with HB of 7.8. This is before intervention. With the counts increased 24,000 and neutrophil count is also.
So this
on
is
the
important,
side.
as I mentioned. So you need to see that blood investigation. If the counts are high, you need to start the antibiotics. Okay. Then next.
However, his renal profile was normal. Urea of 24, creat of 0.5.
If you can see the 19th of June. This was previous investigation. When urea was
Just on the
55.
day of.
Okay. So if the urea is high, you need to hydrate him properly before doing any imaging also.
Yes.
So that is important. That you need to check the kidney function test. Okay. Next investigation.
Liver functions, we have to check for the liver functions, sir. His total bilirubin was 1.1 with direct of 0.5. OTPT were on the normal side.
Okay.
However, alphos is on the higher side, stented patient. INR is slightly on the higher side, sir, 1.66.
But what you said regarding the ALP,
Sir, it is on the
ALP,
higher side, sir. 458. It is on the higher side.
so it was
Stented
922 also. The what this is this what this implies.
Sir, one is stented patient, so it is always on the higher side. Stent block cholangitis is also increases.
Yes, and there is a stent block, there is a biliary obstruction. Okay.
Yes.
Then INR,
So INR is 1.66, sir. It's on the higher side.
Okay.
And his CA99 is also on the higher side, 1000.
Okay. And what is the when you should do CN19-9?
Ideally, when the patient is not jaundiced and not having any cholangitis.
So this patient has a count of 24,000 at present.
Yes.
Your bilirubin is slightly decreasing, and so
Yes, sir.
I think it's not the right time to do, because why CN19-9 increases in this condition, in this case, why we should not do it?
Cholangitis. So currently he's having cholangitis.
In those cases can be falsely high. Okay, so what is your next plan now?
Sir, now first the patient, once the patient stabilizes, then I would like to review the investigations of this patient, sir, in the form of PET CT.
PET CT.
PET triple, yes, sir. PET CT, I would like to see the PET, and then
This you would do when you would do this, like patient is patient cholangitis settled down.
at least 2 weeks I will wait for the next PET, sir.
Okay, so you routinely do PET CT scan in case of CAGB neck.
Yes, sir. We will routinely do, sir.
Okay,
In all CAGBs, we will routinely do PET CT.
okay, so what is the benefit of doing a PET CT scan in a CAGB?
Metastatic work for metastatic workup, sir.
Yeah, what is the incidence of finding PET positive or finding a metastatic disease when you do CT scan over PET CT over CT scan?
Not aware of statistics, sir. I'm not aware.
You should, this is important because you are quoting suppose a center which is doing only CCT and taking a call whether to operate or not, and doing a PET CT scan. So in how many percentage of cases you will find metastasis? So you can like save a diagnostic laparoscopy or it came out positive. So you should know this figure. This is important actually.
Okay.
If you because if you are doing it, this is fine, but you should know that why I am doing this, to rule out metastasis, and how many percentage of cases this will going to benefit me.
Yes, sir.
Okay. What are the things you will see in CT scan to rule out, say, patient is having metastatic disease?
For metastatic disease, sir.
Yeah. Not in CT scan. Let's discuss CT scan first.
Okay, sir. First, I would like to see the extent of the disease obstruction.
Okay, done that.
Okay. Yes, first is the primary confluence and secondary confluences we have to see.
Okay.
Third we have to see is the local infiltration, sir.
What are things you will see in local infiltration?
Total mean, hepatic artery, the right hepatic artery and hepatic artery proper, whether it is involved or not involved, we have to see.
Okay.
Third, nodal disease we have to see, sir.
What also you will see on CT scan?
HDL HDL lymph nodes.
HDL lymph node. HDL lymph node is a broad terminology. Can you tell me station wise which all stations you will see?
Yes, sir. 12, 13,
okay,
16, sir. 12, 13, 16.
Which 16 group of lymph node?
Para-aortic group of lymph nodes.
Okay. Any other? What are the? What is 16? A1, A2, B1, B2?
Oh, sir,
What is 16 B1 lymph node, which we characteristically see?
Intra-aortic.
Not intra-aortic. Yes, intra-aortic lymph node. Yes. So, if intra-aortic lymph node is enlarged, suppose on CT scan, what will you do?
Endoscopic biopsy and US guided biopsy I like to have to see for metastasis deposits.
Okay. One lymph node is this intra-aortic. Any other lymph node that is characteristic of advanced celiac group of lymph node? Yes. So if the celiac group of lymph node is present, you would also like to target them if feasible. Okay, apart from this, okay, you have done the local extent. T done. T you mentioned about the local extent, then you nodal TN, and then
Sir, metastatic for
M, what you will look for?
the liver, any liver mets or any distant
Liver as
mets.
well. Distant mets
Lung,
in the
any,
peritoneal cavity.
in the peritoneal cavity. Yes, sir.
You will look for
Momentum.
any momentum deposits, peritoneal deposits.
Yes, it is.
So you will do PET CT scan in this case. Okay. So have
Yes,
you done
sir.
PET CT scan already done?
No, sir. The patient has recently got discharged after we have given him 2 weeks to come, sir. After that, he will come.
Okay. Suppose his PET CT is all right. Then what is your plan?
So then the plan is to again repeat. I mean, at the time of the PET only, we will repeat the CT again once. We will see. I mean,
You will do the PET CT. You told me again CT.
Yes, sir. No. PET CT. In the PET, we will do triple phase CT. We will do. In that now we will see
Usually they do
extent-
single phase. When they do PET CT, they do only single phase. They don't do triple phase usually. Okay. Okay. Do the PET CT scan then?
Then we'll plan for surgical management. In this case, because the confluence, primary confluence is involved and it is going almost up to the secondary confluence. This is the right hepatectomy. We have to plan for right hepatectomy, sir. Modified extended right.
What are the prerequisite or what all things you will see before planning this procedure in the
Sir.
preoperative optimization of the patient?
So first is general condition of the patient. Second is the lab parameters of the patient in the LFT, especially with LFT and RFT, and we have to see the for this.
In liver function test, what is specifically you will see?
Bilirubin should be less than 2, sir. 2 or less.
Less than 3 is a usual thing. Okay. Then apart from this, bilirubin.
OTPT we have to see, sir. OTPT should not.
Okay. There is no transaminitis. Then
Albumin, sir. Albumin and INR.
okay, albumin is low. Then what you will do?
Albumin is nothing now as specifically, sir. But INR we have to see. Anything
If albumin is low, you will like give patient a high protein diet.
high
Why
protein
will
diet.
not do anything?
Okay.
Albumin is low, you will not do anything. You have to supplement the patient. You have to give high protein diet
High protein diet.
to the patient. This is important. No? Nutritional parameters are
Nutritional
important.
parameter.
Though it is not a nutritional parameter, but this will, like, you will see that patient is optimized or not because you are planning a major surgery. So if their albumin level is low, you will optimize him properly. You will. Okay. Then what next?
Other than that, renal functions are important.
You have seen that counts are normal, renal function tests are normal. Okay, LFT is improved. INR you have checked. It is gradually improving now.
Once everything is settled, just CA99 for a baseline. We have to get a one baseline CA99
marker. Okay. Okay. Done. Next.
Anesthetic workup. So that's anesthetic checkup for the
Anything else
patient.
you would like to see? You are planning a right hepatectomy of this patient.
Yes, sir. The ductal system now we have an anatomy of the ductal system we have already seen.
Okay, done. You have seen would you like to see from where the segment 4 artery is coming?
Yes, sir.
Would you like to see what is the volume of the left lobe you are going to leave?
Yes. Ideally, in the patients, I mean, where there is no cirrhosis, no features of cirrhosis, even with a right hepatectomy, said that there is no need to look for the volumetry because around 30% of the liver volume is present in the left lobe. So,
if suppose there is an small atrophy of segment 2 and 3,
there is an atrophy, yes, sir. There is any
because
atrophy.
you are not going to do a proper right hepatectomy in this case. You have to extend it onto the 5th segment.
Yes.
Okay. So this is important in this particular case because though the volume is okay, but still you before doing this major surgery, if it is a formal right, then it is okay. But if you have to extend it, then because you have only 2, 3, and 4A left.
Okay.
So to prevent any post-operative complication, it is better to see it once. Okay. Any other thing?
No, sir, nothing.
And in which segment of the liver you like to place a stent, preferably in
Left
this?
side, sir. In this patient, left side, sir.
Right. So, but in this case, I think the stent was in right, if I'm not wrong. And sometimes if you place stent in the left and still the patient has fever, then what is the cause? Because this is the undrained, because this is the
Undrained
was in the
segments.
right side. So you need to either you can take a help of an our endoscopist to put the stent preferably in the right posterior or the right anterior sectors, and that is not feasible, what you will do?
PT, BD, sir.
PTBD, but yes, PTBD is required because you need to drain it, otherwise patient will not improve. Okay, Anand, can we wind up?
Sir, we can wind up as I have one question.
Yeah,
You have seen this MRCP image. What do you think? Yes.
This is actually
In this
very good.
MRCP image,
Can you zoom it?
can you make out is a hyalocolangio or CAGB neck or something else is there?
It is very difficult in this MRCP, but in CT scan, if the thickening is present in the neck of the gallbladder,
We are not sure definitely that there's thickening or not still the gallbladder neck.
then in those cases, like you can do an EUS also. EUS can give you a picture whether it is a hyalocolangio or it's a CAGB neck, but going and if see, there are 2-3 things for which you can differentiate, because the management will change, like whether do a formal right if it's hyalocolangiocarcinoma. If it is a CAGB, you need to remove some part of segment 4B also. Okay, so if there is a thickening present in the gallbladder neck, then you will think that this is more to be a CAGB. If suppose gallbladder is absolutely normal and only the thickening is restricted to the hilum, then it's more likely to be a that is why a CT scan after, like say 2 or 3 weeks would be important in this case, because at this point of time patient is having cholangular abscess, CT picture is also not very clear. So, and if you have to further rule it out, it is an EUS sometimes help us.
Can we think of PAC in this case?
Primary sclerosing cholangitis in this case.
Looking at the picture, does it look like PSC?
Not look like classically, because there is in the picture is slightly different, not like this. Why are you thinking in terms of PSC?
We are not able to see any mass lesion in this, and we are thinking this.
As you know, Dr. Anand, that hilar or this
There is fibrosis.
This can it can be a mass forming, it can be ductal infiltrating type, and in our setup we are predominantly seeing a spreading type of malignancy. It is spreading like going till the intrapancreatic CBD and in the secondary confluence also, and still there is no mass present. So this kind of a tumor biology is very common in this part of region. So that is why. But yes, we have encountered not PSC, but there are young patients in which we have a very good hilar mass, and when after doing PTBD, the bilirubin decreased, and when there was on CT scan, the findings were matching hyalocolangio, but when we followed him, like as the bilirubin decreasing, his thickening also started decreasing. We got the IgG4 done, and this came was positive. So this can be a possibility, but in this case, because an elderly male smoker, a short history, I think it's more of favoring malignancy. And if you have to further rule it out, then you have an option like you can do some breast cytology or you will get a FNAC from that mass. That is also possible if you have a doubt, or if the patient clinical condition is because usually in case of malignancy, bilirubin don't decrease so drastically, but in benign sometimes it decreases. So that can give you a pointer towards.
Okay, sir. Thank you. Thank you for moderating today's session.
Thank you, Sandan.
And we have one question. Dr. Jitendra asked for regarding weight loss. Is what weight? How much is the weight loss considered significant weight loss?
This Krishna can give you an answer, I
Yes.
think.
Yeah.
Yes, sir. 10% weight loss, unintentional weight loss over 6 months, or 5% unintentional weight loss over the 3 months. It's considered significant.
Unintentional is important, and this is important. Correct answer.
Thank you, sir. So we are closing the session. Thank you. Thank
I
you.
hope I have given the justice.
Thank you, sir. Yes. Okay. Thank you, everyone. We are closing the session. Thank you.